event, Amputation, Rehabilitation, and Race in America. Our guest speaker today is Dr. Felucio Fakariri, a cardiologist from Mississippi, who will share his experiences and insight into racial disparities in medical care and outcomes with the Carthage community. A quick housekeeping item: please put your questions in the chat. Later on, I will be back for Q&A. Before I hand things off to Dr. Fakaridi, I'd like to take a moment to thank Dr. Carol Sabar for organizing this event. I would also like to thank the Center for Faith and Spirituality and the Division of Student Affairs for launching the Red Bracelet Project. If you're unfamiliar with this program, the Red Bracelet Project is part of the college's commitment to anti-racism. Students, staff, and faculty who want to participate can pick up a red bracelet at offices across campus. These bracelets symbolize the fight for justice, our mission of creating a world where all people can flourish, and that it is a community effort to imagine a new way of being and make them a reality. The red bracelets symbolize each person's commitment to anti-racism work at Carthage and in the world. Students that attend at least 3 Red Bracelet Project events will earn a special t-shirt. I hope that you all join me in this commitment to anti-racism. Now I'd like to introduce our guest speaker. Dr. Felucio Fakariri grew up in Nigeria and immigrated to America as a young teenager. He attended college in New Jersey, where he obtained a Bachelor of Arts in Biology and a minor in Economics from Rutgers University. Dr. Fakariri received his medical degree from UMDNJ Robert Wood Johnson Medical School in Camden, New Jersey. He completed his internship and residency in internal medicine at New York Presbyterian Weill Cornell Hospital. During his fellowship, Dr. Fakariri was honored with the distinction of Chief Cardiology Fellow. He specializes in preventative cardiovascular management, women's heart health, and catheter-based procedural focus on coronary arteriosclerosis disease and peripheral arteriosclerosis disease. He has advanced technical skills in limb salvage and specializes in advanced minimally invasive techniques in treating patients with peripheral arterial disease. He is also a key opinion leader in the treatment algorithm of peripheral arterial disease. In 2015, Dr. Fakariri started Cardiovascular Solutions of Central Mississippi with a mission to educate and provide quality access healthcare for all. He has become a national voice in the fight on the impact of health disparities in underserved communities. He's an active faculty member on multiple advisory boards for pharmaceutical and device companies. Dr. Fakariri has provided multiple keynote lectures on eliminating peripheral arterial disease disparities on the local, regional, national, and international platforms. Excuse me for my mistake. In 2018, as part of the congressional delegation, Dr. Fakariri testified on Capitol Hill in Washington, D.C. regarding the epidemic of peripheral arterial disease and spearheading the Sprint to Zero amputation campaign with policy actions proposed to stop unnecessary amputations. He traveled to Cuba in October 2018 as part of the congressional delegation to discuss the impact of diabetes management on the peripheral arterial disease pandemic. Dr. Fakariri has established partnerships with lawmakers, community, industry, university, and faith-based stakeholders to facilitate cardiovascular education, promote nutrition coaching, highlight social determinants of health, improve access to quality care, and engendering trust in underserved communities. You may not have had the opportunity to read the American Amputation Epidemic. If you have not had the opportunity to read that piece of work, I suggest making time to do so. I would like to share a quote from that article. Dr. Jennifer Smith, a professor at Florida A&M University College Law, wrote the following in the National Lawyers Guild Review and was quoted in this article as saying, "While roots of unequal and inequitable healthcare for African Americans dates back to the days of slavery, The modern mechanisms of discrimination in healthcare has shifted from legally sanctioned segregation to inferior or non-existent medical facilities due to market forces. Now, I would like to turn it over to Dr. Fakariri and welcome him. We are honored to have you speak today. Thank you.
Good afternoon. Thank you, Carolyn, for that wonderful introduction. And I want to thank Dr. Sabar and the Carthage family for the privilege of invitation to speak to the faculty, the students, and community navigators there who are all with us in our fight to bridge the gap in health disparities in care and access to quality care. I'd like to share my screen at this time and give you a brief presentation that will take a couple of minutes, and then we'll take some questions later. All right. I need the host disabled. So I need to be able to share my screen. I'll just ask for permission to share my screen, please.
All right, go ahead. You should be good.
Thank you. All right. All right. So for those who have not been to Mississippi, I like to start with this quote. To understand the world, you must first understand a place like Mississippi. And if you have not been to the Delta, you have not seen the world. Where I am speaking to you now is a town of 12,000 in terms of population in the city and county would be about 18,000. Cleveland, Mississippi is in the heart of the Delta, split in half in terms of 50% African American, 50% Caucasian in population. There are multiple industries, but mainly a farming industry down here and the healthcare industry. But it's also home to the Grammy Museum. And of note, Mississippi holds the record for having the highest number of Grammy Award winners or nominees out of any other state. Hence the second Grammy Award museum that was built here in Mississippi, the first being in Los Angeles. And below is our clinic. But it's also home to an epidemic that has preceded not only our generation, but it's caused an intergeneration or multi-generational scar. And that is when patients who have risk factors for a disease called peripheral artery disease, and it's a mouthful. It's hard to repeat on multiple occasions, so good job, Carolyn. But it's an epidemic that has led to the dehumanization of how we think about healthcare. And I wanted to highlight some of the fissures that are based on what I call social determinants of health and how race plays a role. And how we need to awake the moral consciousness of America. And that's highlighted in that ProPublica article by Lizzie Presser and myself, where we talk about subject matters that span the whole spectrum of healthcare, from lack of preventative strategies to the lack of procedures to save limbs, particularly disproportionately affecting the most marginalized and most vulnerable. So what is peripheral arterial disease? It's basically the buildup of plaque and cholesterol called waxy substances known as atherosclerosis that leads to the narrowing of the blood vessel. And if you don't have good enough oxygen-rich flow to your organs, you have an impairment of that organ. And so if narrowed enough and leads to a narrowing of the blood vessel in the brain, you have a stroke. If it happens in the heart, you have heart disease or heart attacks. If it happens in the kidneys, you have kidney disease. And if you have it in your lower extremities or upper extremities or any major vessel outside of the heart, it's known as peripheral arterial disease. And if it's not treated on time, it can lead to the end organ damage known as critical limb ischemia, where you have a non-healing wound and ulcer. And that is treated primarily with a amputation first strategy, which the analogy I would use is if you can imagine your kitchen sink pipe that is clogged up at home, and you call a plumber, and the plumber tells you to get rid of the whole entire kitchen rather than unclog that pipe with a roto-rooter or whatever mechanism he or she chooses to. So why do we fear peripheral arterial disease? We fear it because it's similar characteristics to cancer. It is slow. It is asymptomatic, meaning people just don't feel pain all the time. And it has a very high co-prevalence with heart attacks and strokes, and people die from consequences of peripheral arterial disease. It is the most prevalent, it is the most deadly, and it is the most chronic condition that most Americans have never heard of, and extremely prevalent in certain populations. We have an increasing aging population with a growing octogenarian population, those in their 80s. We have increasing diabetic population. 1 in 3 people who are watching this webinar will be a diabetic by the year 2050. And we also have an increased epidemic of being overweight or obese, which predominantly affects about 50% of the population, particularly minority populations. A combination of those leads to risk factors that lead to the buildup of plaque and cholesterol, atherosclerosis, that eventually will lead to bad adverse outcomes. Prevalence of peripheral arterial disease is about 20 million. As you can see, diabetes and venous disease are the only two conditions that are pretty much higher. And we have an epidemic that preceded the current pandemic. Diabetes and obesity, that I call diabesity, has a clinical, economical, and human impact, and has typically affected states that are located in rural areas or in low socioeconomic statuses. So if you look at the map, you look at southern states, you look at states that have a high population of African Americans, Native Americans, and Latinx patients, you see that it also costs our healthcare system a lot of money. So why is there regional variability in care? Look, if you look at this map and you look at the amputation rates in America, it's shocking. And as we mentioned in our article, if you look at, during slavery, a lot of African Americans were brought to the South where cotton was king. And in states like Mississippi, that was once considered the fourth wealthiest nation or regions, correction, fourth wealthiest region in the country, you tend to see that, that was mainly gained off of slavery and labor. And part of that history is still, is still present today in that Mississippi has a 40% African American population. And majority of these patients reside here in the Mississippi Delta, which has one of the highest amputation rates in the country. Also has one of the lowest revascularization rates in the country. Revascularization means that the procedures that should be done to unclog vessels that have high plaque buildup, known as peripheral arterial disease, those procedures are known as revascularization, and it can be done via minimally invasive procedures or surgical procedures. And the lowest number of those procedures are performed in where you have the highest Black populations or highest aging populations or highest diabetes populations. So here's a patient who had plaque buildup in his legs. Here's a mechanic with 3 kids, came to see me in the hospital because he had plaque buildup in his legs. This was basically 3 months to moving down here to Mississippi. He makes about $39,000 a year, and he had risk factors for peripheral arterial disease, but had not been screened up until that time. He had a non-healing wound and ulcer. So we took him to the cath lab where we did what we call an angiogram, and we had a successful revascularization of that leg where he has good blood flow to his leg, as you can see here. What happens to that man is that on Thursday, I revascularized his legs, and on Monday, after I coming back from a short trip, his legs were amputated. So why were his legs amputated? Because that was the norm. When a patient has a non-healing wound, an ulcer, an amputation is the first option that is given to that patient. And in spite of my presence at that hospital and the fact that I took that patient to try and save the man's leg and told him to wait and give it time to heal, he was offered an amputation while I was not there to advocate on his behalf. And as the US Surgeon General stated, is that our healthcare system spends close to $1 billion a year on amputations, but we spend the least amount of dollars to address or prevent the diabetes that leads to the amputation in the first place. So why does this occur? It occurs for multiple reasons. That gentleman that I just mentioned had a fourth grade level education. And after I extensively went over what we had done and the fact that he should not undergo an amputation, he was scared of another physician who came in with a white coat and said, no, you do need an amputation, and didn't know any better. I have a saying, you don't know what you don't know, and you can't be what you can't see. And so at that point, it was a power struggle. A physician who is, has multiple layers of education comes in and walks in with a white coat and says, you will undergo an amputation for a non-healing wound. And there weren't policies within that hospital structure to save his limbs. And the only one advocate that was there to do so happened to be away for the weekend. That is a problem. And the US Preventive Service Task Force that was founded in 1984 has this extensive portfolio of services to improve the health of all Americans based on evidence-based recommendations about preventative services. And that's how it's led to things like cancer screenings and other um, um, health disease states that are recommended for CMS, which is the Centers for Medicare and Medicaid, to actually reimburse primary care doctors who treat these patients. So if you're a diabetic and you go see a patient, you go see a primary care provider, you should get screened for peripheral arterial disease. But the USPSTF has actually said that there are certain patient populations that are lacking when it comes to screening. And when you don't have evidence that actually includes these patients, majority of whom are either minorities or live in rural areas or live in what I call the amputation lotteries of America, where they don't have access to quality care. Most of these primary care providers don't screen these patients, and then they end up undergoing an amputation. So what happened is when I moved here, I came to Bolivar, and what I decided to do was to start an aggressive population screening where we advocate for patients, we screen them on time, and we give them a chance to heal before they get amputated. And we saw a significant reduction in amputation rates by 88% over a 3-year period. And I predominantly have an African American population. And if you look at the rates of amputations, it's well documented in African American, Hispanic, and Native Americans. There are multiple articles, and I'm not going to bore you with those details today. But if you look at the comparisons between races, you can tell that it's 2 to 4-fold. It's sometimes in terms of just your rates of not only getting peripheral arterial disease or its risk factors, but in undergoing an amputation. And these are 10 important articles to date that has shown that there are disproportionately higher rates of amputations in minorities compared to other races. And people ask, well, how come? Is it just the diabetes? Well, yes, diabetes plays an important role because diabetes leads to a faster buildup of that plaque and cholesterol called atherosclerosis than a non-diabetic. So these patients present with late-stage disease when they get seen. Some of them have neuropathy in their legs and therefore cannot feel or sense. And so by the time they get that wound and ulcer, it's too late. And when they present, they are offered an amputation before a preventative strategy. The diabetes amputation rates are as high as 28 times higher than a non-diabetic. And the cost to take care of these patients is about a quarter of our whole entire healthcare burden. What is sad is the death rate from amputation. 80% of amputees are dead within 5 years of an amputation, particularly if you're a diabetic. 25% are dead within a year. So going back to that screening and the lack of a recommendation by the USPSTF, what transpired is that they gave it a recommendation that said there was insufficient evidence to assess the balance of benefits and harms of screening for peripheral arterial disease in certain patients. And they gave it an I statement stating that there's evidence that peripheral arterial disease is disproportionately higher among racial and ethnic minorities and low socioeconomic populations. And they note that the I statement could perpetuate and discourage testing and perpetuate disparities in treatment and in outcomes. However, these well-established disparities in care was not enough. They were missing evidence on screening and treatment in particular groups of color. So if you go back to all the data I just mentioned, I guess they skipped and missed that data. And what transpired is that if you look at a lot of industry studies that are out to date, and for all of you who are interested in research, if you look at all the cardiovascular trials to date, only about 5% of African Americans have been included in all trials. 1% Hispanic, Native Americans, non-existent. And so we use data that target the population that we want to target and does not populate these patients that need to be populated because, historically, there's just been a mistrust between these communities of color and our research arm. And you can go back to Tuskegee, you can go back to, the slavery days where gynecological surgeries were performed on African Americans without anesthesia. You can go back to the 1918 flu pandemic where African Americans too were not considered in their treatment algorithm. And so when you have a leg attack or advanced peripheral arterial disease, and you're dealing with a wound, it's kind of like having a heart attack. Time is important and time is muscle. And for some reason, we have considered that conservative treatment to chop someone's leg off is better than an aggressive treatment to do an angiogram and revascularization procedure. And those are words of one of my mentors, Dr. Craig Walker. And so if you look at the amputation lottery, as I mentioned, a lot of people, like the patients I highlighted in the Black Epidemic, ProPublica article, you can tell how their lives and the lack of a high literacy level or health literacy level, their educational statuses and their access to food deserts, and the fact that they're economically disadvantaged, and the fact that majority of them don't have access to quality care can all lead to an amputation and eventual death. But there's also another arm. When you talk about the end stage of this disease, amputation prevention and wound healing requires a multidisciplinary team. Majority of these teammates are not available in rural areas like here in Cleveland, Mississippi. A lot of our incentivized programs to get physicians or medical students to think about rural care sticks mainly to primary care, but majority of them avoid specialty care. And so specialists are not incentivized to come to these areas on their own. And so it led to getting involved in advocacy, because when you see something that is bigger and greater, just as it occurred during the civil rights era, when you see an injustice, what you want to do is you want to publicize it. And so I took a patient to Washington, D.C., serving as a role as the PAD initiative co-chair for the Association of Black Cardiology. And with other multi-stakeholders, we testified about how this young lady lost a limb at age 54 and lost another leg about 5 to 6 years later because her diabetes was not screened. She was an educated woman. She was one of the first postmasters in the state who was African American. And Unfortunately, she died a month ago. But that advocacy work led to the establishment of the PAD caucus, which job is to educate Congress about some of the impacts that peripheral arterial disease has, not only from a clinical but also economical standpoint, costing our healthcare system billions of dollars, 90% of which can be avoided and treated um, if treated and screened on time. So there's been legislation that's been introduced to the House of Representatives with the goal to not only raise awareness, because majority of Americans do not know of this term called peripheral arterial disease. We know about heart attacks and strokes, but we don't know about the sister, which is per PAD. Two, we need to establish coverage for all patients at no cost sharing to them. We need to disallow some kind of payments or disincentivize amputations that are performed without appropriate screening. The analogy I would use is if a woman who has a lump in her breast goes to see a surgeon, you don't just go for a mastectomy without undergoing an ultrasound or biopsy and getting pathology first. That is the analogy. And lastly, is to require some development of quality measures through HHS to decrease amputation rates. So as Martin Luther King said, morality cannot be legislated, but behaviors can be regulated. And the job of our policy makers is not necessarily to change people's hearts, but to restrain the heartless, to restrain those who might not love people, but will want to chop off their legs, similar to what happened in the civil rights movement. So a call to action, as I wrap up shortly, is to form strategic multidisciplinary partnership in raising awareness, which is what we're doing today. I need to speak to not only medical folks, but I need to speak to non-medical folks as well. People who are in our colleges need to understand what's going on with our healthcare system, because you are educators, the lifelong educators who are the best at teaching. We need to expand community-based research and include the communities that are affected by collecting data to inform policy and implement them and evaluate them. We have to assess social determinants of health. And I'm glad that not only is this term making a resurgence, but everyone, including policymakers, have a focus and a bullseye on it. We have to advance policy and system change in all policies to prevent amputations. We have to ensure that our workforce all over diverse and represents the population we treat. And that engenders and facilitates a care-seeking behavior by building trust. And access to quality care is very imperative in our healthcare system. And we have to make sure that unaffordable costs to patients and societies are addressed with a quality improvement target, and target also our up and coming medical schools, nurses, to include that in their curriculums. And as Carthage is doing today, include awareness in your curriculum and discuss health disparities and social injustices in your curriculum. And that will eventually hopefully lead to recruitment and retention of specialists or people interested in the topic in different regions of the country. And so put your passion and purpose together. We are hope dealers. We believe that, despair is the poor chisel to achieve, justice. And that is what we're doing here in Mississippi. Thank you very much for your time, and God bless. Open for questions.
Thank you so much. That was an awesome presentation, continuing to learn more about this topic. I have a few questions so far, and just a reminder, if you have questions, please put them in the Q&A. I know I said chat, and I apologize for that. Um, I had a question that came in regards to the gentleman that you spoke of, the mechanic. What will happen to him, and what has happened to him in
Well,
terms of his life, and is he working? What
sure,
is he doing now?
sure. As I said, 80% of patients who undergo an amputation are dead within 5 years, is one of the evils of amputations. The other evils of amputation is that 80% of them will never ambulate again. 90% will have some form of chronic pain. The cost to take care of an amputee is about $100,000 a year. And if I told you that it's a 5-year kind of life expectancy, that's about half a million dollars, with the median income of a Mississippian being about $35,000 to $38,000 a year. And a lot of them have mental health issues and chronic pain, and we have a chronic pain epidemic, as you know. Speaking of the gentleman, he passed 2 years ago. He died 2 years ago, and he died of a heart event, as I mentioned. It's a violent and painful, isolated death that they endure, because this has been a chronic problem that has led to them seeking help from the system that is set in place to do no harm. And if that is what we as physicians who carry this apron of humility, our providers, our policies really don't reflect that. And unfortunately, his kids now have to live with that generational or multi-generational scar of losing a dad at a young age, and have to deal with the financial, clinical, and economical and emotional consequences of that.
Thank you. I'm getting several questions are coming in, so and I appreciate that. Thank you all so much. I'm going to start off with a question from Deborah Minsky Kelly. She's a faculty member here at Carthage College, and she said, "I teach a semester course on psychological trauma. There's evidence that exposure to early childhood trauma is strongly associated with adult health risk. What are your thoughts about the association between early life adversity and toxic stress and the rates of poor health outcomes in communities of color?"
I think it speaks to, thank you for that question. I think it speaks to what I mentioned in terms of social determinants of health, because if you look at the series of things that comprise the social context, and in social context, you're looking at not only the stress, so that could be the emotional stress, but also discriminatory stress. Statistical discrimination is a term I use, whereby a patient walks into a room and the provider sees that patient, and based on how he or she has treated patients who share similar characteristics of that patient historically, that is what will determine what you get prescribed. So if you walk in as an African American or someone who's poor or someone who's not educated, and you have a non-healing wound and ulcer, guess what's going to be prescribed? An amputation. Because that patient does not ask questions, because they don't know what the other alternatives are. They don't know what a second opinion is. The majority of these places do not question doctors, right? So they come in with that notion that doctor knows best and will prescribe the best option. And that's not always the case. And some of these doctors are not even incentivized to even learn about PAD or to know what it is and to prescribe the best therapy. And so you put that together with the fact that access to care is an issue in these areas. I can see where her question, yeah, there is an impact if you see grandma undergoing amputation, your mother undergoing amputation, and you think that you as a diabetic now will deserve an amputation because that has been your birthright generationally. Very fascinating and very interesting to study, but I think it all falls under the social determinants of health spectrum. Absolutely concur.
Thank you. Carthage Professor Becky Hornung asked, from your experiences with the populations that your patients represent, how might researchers build trust within this community to conduct research? I know this is a hot button question a lot when it comes to COVID-19 recently as well.
Yeah. So all COVID-19 has done is to unblind the fissures and basically the health disparities that have plagued this region for a long time. And we're woken up the moral consciousness of America post George Floyd and everything else, right? We've had a series of events, but also now we've had a pandemic that shows that the most vulnerable get disproportionate care and have the worst outcomes. And so in terms of the question about how do we, what facilitates trust, when you go to a community that has historically been violated in terms of just all the codes you can think of to help prevent them um, from undergoing medical treatments that were just not prescribed or were not validated. What you see is that they now pick on something to hold on to. And that hope is usually found in either the faith based community or it's found in someone who looks like them, who's in the medical community. So, who is an African American researcher, for instance, or who is a PI in a study, who understands the strengths and weaknesses of that community, can go to them and speak to them at the level in which they understand. And even if you don't look like them, because not all my employees, for instance, are Black. Um, they're white. But guess what? We all go into these churches together and they learn. They learn about the strengths and weaknesses. And what happens is that journey will lead to just kind of an understanding where people will, let their guard down and see that you really care. And it's called compassion. It's not just empathizing, but just compassionate, patient-centered care. And if you offer that, then it engenders trust and it facilitates care seeking behavior where they'll come to you for everything medically related, even if it's within your field or not. We've seen that a lot here, and that's what's happened. This whole pandemic and Black amputation epidemic article led to a lot of calls from all over the country where people are asking me, who do I go to save my limbs in different regions of the country? That is what you see. And so that can occur where we incentivize the more diverse research arm, but also we acknowledge the history in which our research was built on, and what it's done to these communities that are marginalized.
Thank you. Faculty member Cynthia Allen asked, what has been identified as the main reason surgeons recommend amputations versus revascularization? I know you've touched on this a little bit. Is it a combination of their medical training, racism, insurance companies?
Bingo, bingo, bingo. Check, check, check. Yes. So it's a combination of one, the training, right? It's do they get trained to perform limb salvage work? Well, the younger surgeons are getting trained, but you have to know we live in a fragmented silo. We're all in silos when it comes to delivery of care in this space. There are vascular surgeons who do procedures. Um, there are general surgeons who do procedures. There are orthopedic surgeons, podiatrists. So who are the good guys and who are the bad guys? You can't generalize, right? Everyone is individualized, but in rural areas, you tend to find that there are less vascular surgeons. So vascular surgeons have more of a sense or grasp of, what this whole disease state comprises of and what the treatment algorithm should be based on guidelines that we share with them as interventional cardiologists and interventional radiologists. And so when you don't have those surgeons on board and just we're trained to cut when they see a non-healing wound, and they're pervasive everywhere, you're outnumbered. And so what is the incentive for that? Well, there is some incentive, not to the hospital, to the surgeon, because hospitals lose money when you amputate a limb. As an administrator, you lose money in a hospital if you keep that patient there longer than if you provide a service where you save limbs, where they're gone, where they end up at home within 48 hours. If you amputate, they're there for a week or two, then they go to a nursing home, and then they have to go and get fitted for prosthesis that Medicaid in this state does not even provide for, right? And then they have to go home and get a car that fits their current status, and they have to build a ramp at their homes where that's so all that cost to our healthcare system, we pay for it as taxpayers, 75% of that bill. So it's a system that is complex, it's antiquated, it's a system that needs to be revamped. We need to acknowledge that there's discriminate care in how we deliver care here in the United States. And it's not just in PAD, this is just one topic. And until we do so, we're just going to continue this vicious cycle, and it's going to have a generational impact.
We had two questions that came in. They're very similar. That they asked about why does the life expectancy get to be so short post-amputation?
So then, that's why I took time off to describe the buildup of plaque and cholesterol. Most people on this webinar probably have heard of heart attacks or strokes. And basically, what happens with a heart attack or a stroke is that the blood vessel gets narrowed by plaque buildup. And the same plaque buildup that's occurring in your legs is occurring 80% of the time in another vessel in your heart, or 50% of the time in your neck. And so these patients will suffer a consequence, not only the stressor of an amputation, but the fact that the underlying problem was not treated. The medical therapies that were needed to treat the patient were not administered. And so another organ will suffer that consequence. And most of the time, that organ is your heart. And they die of a heart event or a stroke. That's what happens. And so an amputation increases your chances of accelerating that process as well by, for 3 to 4-fold in patients of color.
Dr. Michelle Hancock, a faculty member here at Carthage, would like to know if you could please share again the name of the screening that should be requested.
Yeah, sure. It's called so there are two. One is called the ankle brachial index screen, where you go into any provider's office and you ask that they get screening for peripheral arterial disease. It could be an ankle brachial index where they check a blood pressure difference between your arm and your ankles, and that difference will tell you if there's a disparity, because it should all be the same. And if there's something that interferes with the circulation in your arms for going down to your legs, then there might be something obstructing it. The second thing is an ultrasound of your legs can be ordered. So there are different forms, or a CAT scan. So there are different forms of diagnostic screening. But if you do have a non-healing wound and ulcer and you're told that you need an amputation, the key note is that before you undergo an amputation, you tell them what limb-saving strategies are available or specialists are available that I can go talk to first before you amputate. That's key. And where do I need to go see this person? If you don't have it locally, you might have to drive or have means to find that person. Unfortunately, these specialists are not prevalent in areas such as the Delta, where it was missing before I came here. And so if you look at other neighborhoods in West Virginia, in Alabama and Louisiana, and in Arkansas, and actually parts of Wisconsin, there are areas that are just missing. Unless it's a big academic center, you don't see these specialists. And so policies need to, not only healthcare policies, but the gatekeepers are primary care providers, right? When you have diabetes and you have kidney disease and high blood pressure, high cholesterol, or you smoke, or you're a nicotine user, you go see a primary care doctor. They should be able to screen these patients early on. Hence the cancer analogy. Screen it early so that we can catch it early, treat them medically so that we don't spend a lot of dollars trying to do procedures to save limbs or to amputate.
Could you please spell the name of that screening?
Ankle, ANKLE, brachial, BRACHIAL, index, INDEX, screening, ABI.
Thank you. I have just a few more questions. One comes in from Macy. She said Macy's currently working in healthcare and is also a senior pre-medicine student. What would you like to see future doctors or practitioners do for their patients in order to provide them with the best healthcare options, such as would you recommend offering printouts to patients to help explain options and risks?
So it depends, Macy, on where you are in terms of printouts. You can't see the screen right now, but I use audio visuals to kind of show my patients what a plaque buildup looks like, what a pre-treatment looks like, what a post-intervention screen looks like, what a clean artery looks like, what diabetes does to your vessels, what smoking does to your vessels, what not dieting and exercising does to your body, because the average literacy level of my patient is probably different from someone who lives in a different region. And so what I try and do is to bring it down to the level where they understand what you say, and I get a family member involved in that conversation, so it becomes a shared decision making. So my advice is, number one, make it a shared decision-making process. Two, utilize the strengths of a practice. Nurses, the techs, they spend more time with patients than the physicians do. We walk in a room, we spend a couple of minutes, sometimes longer, and then we leave. And you know what patients do? They look and with their lights on and say, well, I had no idea what this person just said, right? They feel more comfortable with your nurses and your techs. Well, empower your techs, empower your nurses. So they're part of my screening team. My nurses and techs can give this lecture as well. And so that's what I do. I invest in my staff as well. So not only that, make it a multidisciplinary effort wherever you are, and make sure that you treat every patient like a family member. Become an advocate, go out to the community, and make it a campaign. But in terms of just handouts, most patients that I see have a difficult time even reading half of the the intake forms that we give them. And so you just want to minimize that if you can, so you can make it really a very impactful visit.
What are some of the challenges that a rural clinic and or doctor faces that most people do not realize because they have access to larger urban clinics?
Sure. Number one, you deal with the highest chronicity of diseases, but you have the lowest number of physicians per capita in rural areas. And so these physicians are dealing with a high burden of, disease states or problems, and are given 10 to 15 minutes to solve it. And so they have to cherry pick what to do, what medicines to prescribe, because these patients also are poor, the poorest of the poor. And so their copays might not be able to afford them to take, the newest and best medicines that are being, shipped out of, places that really don't think about rural, populations when it comes to the cost of medicines. If you look at pharmaceutical companies and some of these device companies, the cost of affording your diabetes medicines, some of these places just cannot afford it. So these challenges are layered, not to mention these doctors are just ill-equipped with specialists who should be available. Like Mississippi has one of the highest rates of diabetes, but has the lowest number of diabetes specialists in the country, endocrinologists. They're probably less than 10 in the whole state. That is unacceptable. And so the primary care doctors now are left with the challenges of managing diabetes. And so screening might not be the first thing that comes off their bat, right? It's managing all these chronic problems, understaffed, under-resourced, and having to deal with the patient's social determinants of health aspect that our state, local, and federal governments should be the ones to kind of help address that with partnership from multiple stakeholders.
Maddie Perez asked, have you witnessed difficulties post-amputation with your patients, healthcare and or lifestyle wise? Maddie's father recently faced a variety of hardships post-amputation.
Yeah. So as I mentioned, the evils of amputation is real. It spans not only the costs, but also other impacts from mental health to chronic pain to inability to afford prostheses or to be able to get a provider, a family member or provider to help that patient get to their appointments. Because now someone who lives probably in a generational home, and you have someone who's an amputee has to take off of work now. So get off the workforce to come and take someone to a hospital or clinic visit. That's a challenge because now you're affecting the economic stability of that family. That person has to drive them hours to go see another specialist. Our healthcare system, as I said, Medicaid does not cover prosthesis in the state. So once someone gets an amputation, the surgeon does not consult with the prosthetic company and the patient before an amputation. That option is not given to you. It's just chop off your limb and you figure it out on your own. So those challenges are layered, not to mention the worst one is death. They lose these patients, and some of them will have to have a revised amputation of the affected limb, meaning that a proximal level, so they start with the toes, they go to the ankle, they go to the knees. It's systemic and systematic in terms of how they approach this. And so that's That's another challenge that we have to face within our medical community.
And you've alluded to this just in your answer to the last question, but what is the cost to society for having a person disabled in this manner?
Yeah, yeah. There have been different studies. The Surgeon General quoted 800 million. I mean, the numbers I've seen before that, I mean, we've seen as high as the epidemic of PAD and amputations combined is about a $200 billion cost. Funny is that 80 to 90% of that could be prevented. So that is a cost to our healthcare dollars. And I've mentioned that majority of that cost is carried by tax-paying dollars, Medicare, Medicaid, right? So that's about 75%. So if we change our mentality to a preventative strategy where we're addressing the diabetes, obesity, nicotine cessation, community outreach, addressing the social determinants of health piece up front, and coming up with policies that are more preventative, how much money do we have in the reserve to address other things like pumping it into our educational system so that we can have access to care and spend more dollars on getting them insured, and then get more jobs so they can have better insurance statuses, the more commercial insurance rather than just depend on Medicaid. Those are things to think about. So it's not just a financial metric that should be used to gauge our success of our communities. It's actually the health of our communities. And that's why we're having these discussions and these webinars.
I have just one more question to ask you. I feel I was listening to a webinar not too long ago where a gentleman from a foundation was talking about equity in communities, and he said that we're working to go to a place that we've never seen before, that we've never been before. And I would just like to know a little bit from you, what do you see that future looking like for equitable healthcare? I think you've already alluded to that, but just maybe you could expand on that a little bit more. What would that look like?
Sure. I mean, I think that where we're going is to, if you look at the burden of health in America, majority of these states have a lot of the shared characteristics as the Mrs. B Delta, low access to quality care, the lack of addressing social determinants of health. We need to also address some of the unique challenges that we face in terms of our diabetes epidemic, our obesity epidemic. So lifestyle and dietary modification is very important. And that's why community comes to play, because it's going to the community, here in women-driven initiatives here in Mississippi have helped in engaging them early on, and them being kind of the health directors of their families to go out and say, this is what we're going to do, and you need to go see this doctor, you need to go get screened. Engaging other stakeholders, being creative. I think entertainment has a little role to play with this too, because as you've seen with the oncological space, the cancer world, they have raised awareness to the rate where now it's in our entertainment industry. Every NFL, MLB, Major League Baseball, and NBA game, there's some form of an awareness campaign. Well, if we have a disease that costs more than cancer, it's as equally as deadly as cancer, we have not even gotten the half of the awareness that cancer has gotten. Well, we need to start engaging our communities and think outside the box when it comes to raising awareness, but also come up with initiatives that are shared and driven by the community, direct consumer approach, rather than depending just on physicians to be the gatekeepers for their outcomes. That's the number one preventable cause of death, right? It's lifestyle and dietary modification. So we need to do a better job at focusing on that at all levels, from a young age all the way to advanced stages.
Thank you so much. I really appreciate this, Dr. Fakariri. It's been a pleasure having you here today. I think we've got to the end of our time here. I do not have any more additional questions for you at this time. I would like to mention, earlier I did mention the Red Bracelet Project, which I have my red bracelet
Yeah,
on
I need more
today.
of that. I need some sent my way so we can help spread that awareness campaign, and I'm really proud of Carthage to do so, and in helping not only address an epidemic, but in being a force for change, and being committed, because when your purpose is just and your belief is strong, no obstacle can come in your way. So truly, shout out to you guys in trying to address the health injustices in healthcare.
Thank you so much. And faculty and staff as well, if you attend 3 Red Bracelet Project events, you too, along with students, can get a free t-shirt. So in addition to your red bracelet, you can have your t-shirt and join us in this community in addressing racism. Thank you so much. Thank you all for tuning in today, for joining us, and I hope you have a great day. Take care.
Thank you. God bless you guys.